to be here this morning in Houston, and I know everybody is all over the world. So wherever you are, greetings and good wishes for a good, great new year ahead. So I'm going to talk to you about something that I'm very passionate about, which is diagnostic errors. But I'm going to put it in the context of the electronic health record and the health IT environment. So just a little bit of background of what we do and where we are. Since this is our center, we're located in Houston, Texas. It's a large health services research center, and we study essentially anything and everything to do with the healthcare delivery, and pretty much along the lines of quality of care, patient safety, and effectiveness of care. And within this center is my team here. I'm very proud to present to you. We have a great multidisciplinary team that has several disciplines represented here. So we've got informatics, cognitive psychology, social work, as well as sociology. We also have data analysts and research coordinators who support a lot of what we do. And we're going to add a human factors person soon. So this is a good expanding team, and we sort of love to work together to solve some of these complex problems. And what I want to discuss today is talk to you about patient safety risks and challenges that we have uncovered involving diagnosis, but again, put that within the EHR environment, and then talk about potential areas for solutions, and mostly conceptual frameworks. As you know, researchers often use conceptual frameworks to help solve these complex problems, so we'll talk about some of these as well. And if I do get interrupted during a connection, I apologize. There's a very heavy rain and thunderstorm going around in Houston right now, so we might get affected. So just a little bit of a heads up. Let me start with a case. This is a story of a 12-year-old boy, Rory Staunton, who presented to a New York hospital emergency room in 2012 with some vomiting, fever, pain in the leg. He first went to the pediatrician, who said, you look sick, so go to the emergency room. The boy went to the emergency room, was given some IV fluids. They thought he had gastroenteritis. They sent him home. And the next day he got really sick, and sicker actually, and then he returned. And then he had to be hospitalized after that in the ICU, and a few days later he died. Now what happened was, when he was in the emergency room, what they really missed was modeling of the skin that he presented with when he came in for the first time. And modeling of the skin is something you don't see with gastroenteritis. It was, just suspected to be just a plain, simple gastroenteritis, and they gave him fluids. The second problem was his heart rate and his blood pressure never did respond to the intravenous fluids. So that was, again, another problem. Before he sent home, he just hadn't sort of responded to fluids. And the third important thing that happened, which could have led to further deterioration, with what the boy really had was sepsis. And he had sepsis due to a streptococcal infection. It's a bug that he got probably from a little scrape on the gym when he fell down a few days prior to coming in. And he had a WBC count, which is a white cell count, which was really, really elevated with 54% bands, which is suggestive of a rip roaring infection. And all the symptoms, the signs, the labs were all missed, and the child ended up dying. And so this is a very sad case, but it illustrates a very complex problem of misdiagnosis, where somebody presents with clear signs, symptoms, and lab test abnormalities, but those are not acted upon, and that leads to a very poor.
We have
so improving diagnosis. Go ahead.
We had a bit of interruption with the audio, so please continue. Like, you were not long, just literally for a second. I thought it would be for longer, so please continue. Sorry for interruption.
Okay, no worries. So this report, Improving Diagnosis in Healthcare, literally sort of put all this problem together. It's the third in the series of the quality chasm reports that came from the Institute of Medicine, which is now called the National Academies of Science, Engineering, and Medicine, and really highlights the problem of diagnosis in healthcare. And it says most Americans will get a wrong or late diagnosis at least once in their lives. And they made this claim due to looking at estimates in the area. Some of the estimates were our own, and I'll talk to you about them in a minute. These are types of conditions that can occur involved with misdiagnosis. So you have a whole lot of conditions: pulmonary embolism, cancer, acute coronary syndrome, stroke, pneumonia, appendicitis. And if you look at this, this is a list which is fairly broad, fairly representative of common conditions that we see in general medicine and primary care, and again, affects many, many conditions, not just one condition like sepsis. In general, cardiovascular conditions, cancer, and infections end up being fairly well represented in any diagnostic error study looking at a broader population. So you might be wondering, I'm talking about this now, but this seems to be a common problem. Why have we not talked about this before, and what's going on? Why has there been little progress? The issue is the basic science of diagnostic error is really at the intersection of multiple other sciences. So you've got cognitive psychology, informatics, human factors, social sciences, implementation science, art of medicine, all the clinical details that clinicians, discuss. So it's really getting all the disciplines together to understand such a complex problem can be a bit of a challenge. We're also debating what is diagnosis. We often change definitions of diagnosis. We've changed definitions of diagnosis of diabetes, hypertension, sepsis over the last few years. And there's not a good standard for most of these diagnosis-related concepts. And the operational definition of what we call the error of diagnosis is even harder. And this is especially true because, as you can gather, diagnosis often evolves over time. Just because you have a cold today and then you get a sinusitis, a week or 10 days later, and if you go to the doctor on the second day of a cold and he says, you got a cold, and 10 days later you have a sinusitis, that doesn't necessarily mean there was a misdiagnosis on the second or third day of you having a cold. It just means that sometimes conditions change over time, and as more information becomes available and as the disease evolves over time, things really can change a lot. There's also a lot of uncertainty at play along with diagnosis. Things are not really always black and white that we call that we could imagine in some of the other conditions, and these are areas of what we call omission at times, and really it becomes hard to figure out what is a diagnostic error. So in patient safety, a lot of progress begins with measurement. It's hard to improve what we cannot measure, but it's harder to measure if we cannot really define the problem we're trying to solve. So I often like to emphasize that we should all have a shared understanding of what is it that we're talking about in terms of diagnostic error. So I'll talk to you in the next few slides about some of the shared understanding. Now, what the Institute of Medicine report did was it came up with a definition of diagnostic error, which is written here, and they say the failure to establish an accurate and timely explanation of the patient's health problem or communicate that explanation to the patient. Now, if you look at this definition, you will realize there's an or in the middle of those two, the A and the B, which really means you could have either one of these two for it to be a diagnostic error. The other interesting thing is this includes communication of explanation to the patient. So what they did was they took a very patient-centered view of diagnostic error, and this is how they represented what they thought would be the definition of diagnostic error. It also has the word accurate and timely, so oftentimes we're sort of scratching what does accurate mean. We agree on how long ways that we have tried to conceptualize what diagnostic error is. And we define this as what we call sort of preventable diagnostic harm, where the focus should be on area B, which is harm from delayed or wrong treatment or harm from delayed or wrong test. And there could be missed opportunities in the diagnosis that could be due to systems or cognitive factors, which lead to preventable diagnostic harm. But oftentimes there are no missed opportunities when there's delayed or wrong diagnosis, and we really cannot do a whole lot about those missed opportunities. And when there's no missed opportunities, our work, body of work, mostly focused on and still focuses on where there are missed opportunities in diagnosis. This is the representation of the diagnostic process. This is a very nice model that was developed by the National Academies of Science, the Institute of Medicine, where they conceptualize a diagnostic process from the time the patient experiences a health problem and then the patient engages with the healthcare system. And if you look at the circle in the middle, you can see many of the aspects of diagnosis are represented here. So this is when there's a history, a clinical exam, there may be some testing involved, performance of testing, there's referrals and consultations with other clinicians, and they conceptualize a diagnostic process, including communication of the diagnosis to the patient and then ending with treatment and outcomes. I really encourage you to look at some of the conceptual models that are have been presented on the Institute of Medicine's website for this report, because it really gives a nice illustration of how we can understand such a complex process. So I'm going to talk to you about 3 of the 8 Institute of Medicine goals that have relevance within the context of the electronic health record and improving diagnosis. One of the first goals they put forward was to facilitate more effective teamwork in the diagnostic process. And what they said was diagnosis is a team sport. And you can really understand that, right? So you've got the clinician, the primary care clinician, or the ED clinician, the radiologist, the lab, the subspecialist, the patients, the families of the patients, caregivers, and all of these are, these are entities that are involved with making sure diagnosis happens correctly. One of the second goals that I like to talk about is how do you make sure that health IT support patients and the healthcare professionals in the diagnostic process. And the third thing I'll talk about, which is their goal 4, is measurement. How do you use approaches to identify and learn and reduce diagnostic errors. Now, let me first tell you about this technology hype cycle before we talk about electronic health records and technology and health information technology and the use in healthcare. Some of you may have seen this before. But essentially, this has been well described from decades, but it's what's called the technology hype cycle. It begins with the technology trigger, then there's a peak of inflated expectations, and then there's a trough of disillusionment before there is a slope of enlightenment and a plateau of productivity. So I can safely say that many people in the US would feel that we're right now in the trough of disillusionment, but many health systems are now slowly climbing up to that slope of enlightenment, including the ones that I'm working at the VA, where we're sort of at the plateau of productivity. We've gone through some of these challenges, but many health systems are sort of going through some of the challenges. And I wanted to show this slide just to give you an idea. You might be in different stages of health information technology adoption and success, and you might be able to relate to one of these stages. But I want to put this in context before I give you some of the stories that I'm going to tell you over the next few minutes. So our research shows that in the outpatient setting, diagnostic errors occur in about 1 in 20 U.S. adults annually. Now, what that means is we did a study based on and what we found was 1 in 20 U.S. adults would get misdiagnosed in the outpatient setting annually. So if you add up over the year, So we found that even though you had clear evidence to suggest a diagnosis or the need to pursue additional diagnostic evaluation, people would still miss the diagnosis. Now, remember the Rory Staunton story that I told you of the 12-year-old boy. Essentially, he presented with several things that were missed that would have suggested a diagnosis of sepsis versus just plain simple gastroenteritis, which is what he was told the first day he was presenting to the emergency room. We've also shown that there's failure to elicit or act upon key history or exam findings or red flags. So one of the big examples is that the red flag of mottling of the skin in Rory's case was missed. That does not suggest gastroenteritis. And when we look at these cases, oftentimes the question is, do we have enough time to spend with patients versus using the electronic health record to enter data, to and all that. And so we started asking ourselves the question: does the electronic health record influence clinical reasoning and judgment and thinking? And so I want to illustrate one case that some of you may be familiar with, where in a U.S. hospital in Dallas, Texas, a patient presented suggestive of fever. He had a high fever. He also had some viral flu-like syndrome. He had traveled to West Africa. It was clearly documented in the electronic health record notes by the nurse. This was never seen by the emergency room doc who saw the patient. In fact, the note reflected by the emergency room doc said no fever, even though there was 103 fever documented in the nurse's note. And that really happened because they were using templates to capture the documentation of what was going on with the patient, and they probably accidentally checked off no fever just automatically without realizing that the patient had 103 fever and they needed to change that. So in essence, what happened was on the day one, everybody sort of blamed the nurse and said, well, you should have told the doc about the travel history. But that information was available to the doc in the electronic health record. All they had to do was to go to a different screen to look at that. But oftentimes when you ask docs, they may not actually read the nurse's notes. And the nurses feel similarly that docs often do not use the information they're documenting. On the second day, they thought it was electronic health record problem. That wasn't true. And on day 3, they finally sort of realized everything was available to everybody, and there was a very complex condition of sort of a human error, communication failure, and how the electronic health record sort of gets in the way sometimes in a complex ER environment, in an emergency room where there is a non-linear diagnostic process. There's lots of chaos, lots of interruptions when things can go wrong when you use electronic health records to capture all the clinical information. Initially, there were a few lessons learned, but we did write a paper soon after the event happened. But again, this information hasn't just been disseminated widely, so I would encourage you to read the paper to see if you find it useful. It's an open access paper. Now, let me talk to you about another emerging area of risk that we've seen. We've often seen that, as clinicians, we like to do a differential diagnosis to think about what's wrong with the patient and figure out what to do next. And we've often now seen that in the midst of trying to document everything else, the differential diagnosis that we do that reflects sort of our thinking process about what's wrong with the patient is often not done. The second related risk that we've seen is we often don't seek help when we most need it, and this has huge implications for clinical decision support. People think, well, let's just give some decision support to the docs in terms of maybe computerized decision support, even a human decision support, such as looked at how 118 physicians diagnosed some cases. We gave them 2 easy cases and 2 really, really difficult cases based on, this is real world cases, by the way. And what we wanted to do was to assess how the diagnostic accuracy of those clinicians are aligned with the perception of the confidence in that accuracy. So if I'm saying, I think this case is that of polymyalgia rheumatica, just making it up. I am 90% confident, and we did that on a Likert scale, so I'm 9 out of 10 confident that I am correct. And so this is how we capture this information. And here's what we found. If you look at the graph on the easier side, which is on the left, which is graph A, the accuracy was around 0.56. That means 56% of the clinicians got the diagnosis for the easy cases right. And then the confidence was hovering around 0.7. So again, this is sort of a Likert scale, and we converted it down. If you look at then what happens in the more difficult cases, remember, the more difficult cases, you're more uncertain, you kind of don't know what to do next, you're sort of scratching your head and wondering what's next and what you should do. What happened was that accuracy dropped dramatically to about 6%. But if you look at the confidence, it barely budged. Even though there was slight statistical significance in the drop, clinically, there was no real difference in the confidence between the two cases. So we're sort of, extrapolating that physicians remain overconfident in, real life conditions from this vignette study. Another emerging risk that we've described is data display and comprehension in electronic health records. We have a lot of display. Here's a paper where we showed that when there's graphs in electronic health record, they often don't follow any standard format, and oftentimes there are this is high school math, in fact, mathematical problems that are non-standard use of graphs in several electronic health records. So I would encourage you to look at this paper. Again, display of information has been shown to be a problem in not just display of graphs, but several other EHR-based studies as well. And this is not just true for electronic health records, but also for patient portals. So now we're increasingly adopting patient portals. Here are some quotes that the patients told us about their portals. So they're getting test results through portals, and they're saying that the lab results are not organized in any logical order, like by date. This patient said, I have trouble finding the newest result, and the graph, they're just wrong. Another patient said, when I log in, I can see the new labs, but once I've viewed them already, it moves them to somewhere else. I couldn't figure out where to go to find them, and not user-friendly. Again, problems happen not just in electronic health records, but also portals. Now, before I go to the next case, I want to tell you quickly, this is actually a very compelling story that was covered in NBC News of a patient advocate who's a good colleague and a friend of mine, Sue Sheridan. And who you see here is her husband and her son. Her son, when he was just born, had a bilirubin that was missed, and it was an elevated bilirubin that was missed, and he ended up developing severe complications of the brain, and they call this condition kernicterus. And it was sort of because we missed the diagnosis of hyperbilirubinemia. Her husband, a few years later, developed a spinal tumor that was initially called benign. But later he had recurrence, and 6 months later they realized that was actually not benign, it was malignant. The pathologist had gone back and changed the reading after some additional staining from benign to malignant, but this information was never communicated to the patient or the patient's family. Her husband unfortunately ended up dying because of this malignant tumor. So she has two compelling stories right within her family of test results that were abnormal and were missed and not followed upon. So that's what I'm going to talk to you about now. We would hope that with the electronic health record, some of these communication breakdowns would get better, but what we've shown is these breakdowns persist despite EHRs. We evaluated almost 1,200 they flag the report back to the ordering clinician, and the ordering clinician will get the report within their EHR screen, and they will then act upon it. So we found that about 7% of abnormal labs lack timely follow-up, and about 8% of abnormal imaging also lack timely follow-up at 30 days, which means that even though we were transmitting many of these test results to clinicians through the electronic health record, getting them from point A to point B very effectively, we were still missing information because it was not being followed up. So we started wondering why this was happening. One of the things we looked at was, well, maybe the clinicians didn't sort of click on those reports and take some action on them, because let's assume, I'm sure we all get lots of emails. Oftentimes we would not read the email, and therefore we will not follow up and take actions based on that email. So we thought maybe the same thing was going on. So what we did was we looked at the proportions within the situations where clinicians had acknowledged these alerts, as well as situations where clinicians had not acknowledged these alerts, thinking that what we'll find will be, if you don't acknowledge, that's the time you're missing the information. But if you acknowledge and you read the report, you won't miss the information. But we were wrong. There was actually no statistical difference between the two groups, which meant that people would read the abnormal test results but still not take any action. And we were wondering why that would happen. And what we realized was when two clinicians are involved, and one clinician, let's say, orders a test on behalf of the other clinician, for instance. So if I'm the primary care doc, if I send a patient to a specialist, the specialist would order the test. The electronic health record would notify both the ordering clinician, which is a specialist, as well as me as a primary care clinician, because I'm the primary care doc. In those situations, each one assumes that the other one's taking follow-up action. So ambiguous responsibility of follow-up is a huge issue in the outpatient setting. Actually, even in the inpatient setting sometimes. We also found that some of these electronic health record notifications were skipping because there's too many of them. So almost 30% of providers said that they miss test results because of too many alerts. And more digital data is on the way, as you know. Mobile health, smartphone technology, people are using wearables of all kinds, and people think that they're going to collect all this data, and hopefully their docs are going to see it in real time. So we know that more and more data is coming our way, and we'll need to sort of think about how we want to handle it. What we found in this body of work was not just software problems, for instance. So people describe problems with functionality of saving and tracking some of these test results. They said there's too much information. We found usability problems. They said, the screen is really monotonous on the electronic health record. We found workflow problems. So they would, provider would go on a vacation, but don't forward the alerts to somebody else when they're out of office. We found lack of training. We often asked around, so who's responsible for follow-up? Do we have a policy? And we found out that the policies were ambiguous. So what we found was what we call socio-technical issues, and there are multiple issues that were involved in our study. And this is, again, not just one study. We did qualitative work to follow that out. So in general, what are sort of the lessons that we're sort of learning in our work? How can health IT support diagnosis? Well, we're figuring out that health IT itself must be safe. Health IT must be used safely. So what I mean to say is, you could have the best electronic health record. You could have a good notification system. You could have a great communication system. But unless we use that safely, we're not going to be able to make progress. And then we also must use health IT to improve safety. So this is when you try to leverage information technology to identify patients before they are harmed. So in our case, just imagine, could we have information technology that tells us which patients who are getting lost to follow-up, who are falling through the cracks of the healthcare system, who have abnormal results that have not been followed up. And so with that in mind, we developed this framework illustrating this conceptual approach. I'm not going to walk you through the framework because the citation is right there. But in essence, what we say in this framework is if you want to use health IT to improve patient safety, you need to address all of those three things I just described. You've got to have safe information technology. So that means your lab results can't disappear. There couldn't be software glitches, for instance, between the lab and the clinic. We've got to have safe use of technology, which are all the clinical situations I just described. And then we've got to have use technology to improve safety, and that's an example I'm going to show you right now. So here's a study where we use big data to try to build a safety net. We developed electronic health record-based triggers that look for follow-up actions on something that something was going wrong. So let's assume that I have a new onset of anemia, but I've not had a colonoscopy in 60 days. So I am at risk for colorectal cancer because I have a new onset anemia. So the computer knows when you have the new onset anemia. The computer also knows that you didn't have a colonoscopy because it's all coded data in the electronic health record. So we use this big data warehouse to develop algorithms to tell us which patients had abnormal tests that were not followed upon in a timely fashion. We did the same thing for chest x-ray. So if somebody has an abnormal chest x-ray, it shows an abnormality such as suspicious for cancer or a nodule or a mass. And if they have not had a follow-up, let's say with a CAT scan, or they haven't been to a lung doctor in 30 days, we would then extract that list of patients. And we found good results. So these are a couple of the earlier papers that came out, which showed that almost for every 100 patients out of the thousands and thousands of patients that the computer would scan. Remember, this is big data, right? So we've got data on, let's say, 300,000 patients. We would then build the algorithm to identify just a few hundred patients that we need to review in detail to see, do they have a missed opportunity, such as no follow-up. And when we do that, out of every 100 patients we review, almost 60 of them really do have lack of timely follow-up. So it's really effective because right now we don't have any systems to identify these patients through the use of electronic health record data like the way we've described. Some of the patients that we find are sort of false positive. That means they are the ones that the computer thinks that they have not had follow-up, but they truly have had follow-up. The reason we find is sometimes the patient would go to an outside system. So this is the advantage of an electronic health record that carries data from several facets of the diagnostic journey of the patient. If you go to different systems to get your care, the data is not very well connected. So some of these studies that I'm describing could only be done in integrated data systems or data systems that collect data from multiple streams and put it together so we have a good idea of the longitudinal journey of the patient. So we need to evaluate how we are doing, and I want to talk to you about some guides that we've developed which could be used to improve follow-up of test results. These are guides. If anybody has interest in electronic health records, you should look at them. They are patient safety and health IT related guides. It's almost like the first draft of best practices. What is it that you can do within your healthcare system? So if you are a CEO or you are an administrator of a hospital or you're the CMIO, which is the Chief Medical Information Officer, Chief Nursing Officer, any of the administrative people, or you're a quality officer, safety officer, these guides are guides that you must be familiar with. And they're freely available. The website is given below. They're called Safer Guides. They're not meant to be regulatory. They're just for self-assessment. So they are basically risk assessment tools. They're focused on several high-risk areas, of which 2 are relevant to diagnosis. One of them is test results communication, which is what we just discussed, and communication in general. So this is communications of all types, referrals, post-discharge from the hospital, any other type of communication. So I encourage you to look at these guides. This is what they look like. This is just to kind of give you a little bit of an idea. We do recommended practices. We develop them on behalf of Office of the National Coordinator in the U.S. which and it's you know, again, if you look at them, there are lots of good practices. So for test results reporting and follow-up, there's about 23 good practices we recommend. And you look at the practice and you see, are we doing this in our healthcare system or not? And you could say implementation status is partial or not implemented. And does that mean that issue is a risk for us? So it's a self-assessment tool. I want to give you a quick example because it shows you, I described to you through Sheridan's case. So her husband had an abnormal pathology report that was not communicated. So building a big data safety net, for instance, if we had pathology reports that had coded data, such as abnormal normal interpretation, we could extract some of this data through the electronic health records and identify patients who have not received follow-up. Similarly, when test results are changed or amended, for instance, remember I said the pathologist changed the interpretation, you know, in that case, changes are notified to the clinician. So again, these are based on not just technical things, but using a socio-technical approach, including organizational and workflow factors in improvement. There also are huge opportunities for patient engagement and using health IT to improve diagnosis. We're still sort of learning. Here's a study that we did with some colleagues in Australia, where we asked clinicians if they're comfortable releasing abnormal test results to patients directly without going through them. For normal results, 80% of clinicians said, yeah, it's okay, you could just release results directly to patients, but only 20% of clinicians wanted abnormal results going directly to patients without going through them. And so I know in many countries they release directly to patients. Patients have, you know, their results with them all the time. But we're still getting there in terms of the culture change in the U.S. And one of the issues that bothers clinicians, and I think patients as well, because this is patients telling us they actually don't understand all of these results. Here's some quotes: the result was abnormal, but I didn't realize it. One of the other patients said, there's a problem with low sodium, what can I do? And another patient said, I hope they call if it's problematic, because they think, well, no news is really good news from the doctor, and that's not really true. And so putting it all together, you know, this is a model that's been really, really useful in our work in health IT. It's called the socio-technical model. It was described in Quality and Safety in Healthcare, which is sort of the previous version of the MJ Quality and Safety. And essentially, it goes to 8 dimensions, and each of these 8 dimensions have to be addressed in order to improve diagnosis. Improving diagnosis using health IT really needs a socio-technical approach. It's not just technology, it's much, much beyond that. And I'm going to give you examples as I wrap up as to what I mean. So you could have great innovations in the electronic health records, but what would they look like? They shouldn't only be technical if you want to support diagnosis. A software dimension, for instance, should have better tools and functions and design of the electronic health records. So we talked about this. Everybody wants to have more tools that are provider-friendly and give cognitive support to the provider to help them improve their thinking, improve their efficiency, improve safety. We want that. We also want better content. So that means we want alerts that don't overburden us. We want decision support tools that are clinician-friendly. We also want better usability. So the signal-to-noise ratio in some of the electronic health records right now is pretty poor. We need better user interfaces. But then we also need more than just a good electronic health record. So we need time to talk to patients, time to listen to patients and what their stories look like. Oftentimes with technology, it's hard to do that. We also want clinicians who are engaged and patients who are engaged in order to make all of this effort successful. At an organizational level, we need a better culture of understanding, better leadership. I'm glad that there's a lot of administrative leaders on this call, because you all can be very powerful change agents within your organization to do something in safety, whether it's using safer guides, whether it's protocols for closed-loop test results follow-up. We also need better rules, external rules and regulations. So right now, at least in the U.S., we essentially get paid It's a billing-based system, so we essentially get paid to document. So we're documenting a lot of information in the electronic health record. In fact, the Ebola misdiagnosis that I discussed earlier, what was the reason that the clinician was documenting so much in the electronic health record and using the templates, etc., right? The reason was it's all reimbursement-based system. And then measurement. Measurement is really important. I think I emphasized that earlier. But essentially, we should be thinking about what are the measures that matter for safer care. We have all sorts of quality measures and safety measures, but many of them are meaningless. How do we develop measures that are more meaningful for safer care? So one example I gave you was triggers of computerized big data. Could they be used for learning and quality improvement? So these are just the model in action that I just walked you through. So I want to end here. Sorry, I think there may have been a couple of audio problems along the way. I want to thank my funding agencies, including the VA and NIH Agency for Healthcare Research and Quality and ONC, and my team. My email address and Twitter, etc. handle is all here, and I'll be happy to take questions. Thank you so much.